Our assessment of the person who is undergoing some type of violent episode should always include indicators of violence. So I think I've mentioned before that sometimes people have somatic complaints, bodily complaints, and that's the first thing that they'll come to you for. And other things that we really should be looking at are different types of bruises in various stages, wounds or bruises in various stages of healing, and also things that would raise suspicion, such as different types of excuses or reasons why something happened, and it really doesn't seem to make sense in relation to what you're assessing as the injury. So lots of different ways to kind of look at indicators that violence might be happening. We also always have to look at the level of anxiety and the coping responses of that individual person. The anxiety level might be extremely high, and if you think back to when we talked about somebody undergoing post-traumatic stress disorder, which certainly domestic violence, child abuse, elder abuse, all can precipitate somebody developing PTSD. Think about that person being hypervigilant, on edge, unable to relax, unable to sleep at night. So those are all things that we can be looking for and in the level of anxiety of somebody who is going through domestic violence, again, child abuse, elder abuse, any type of abuse situation, and also just how are they coping. They may not be able to talk very openly about how they're coping or about the situation, but of course we always want to try to encourage them as much as possible. Your book talks about sometimes the coping mechanisms used by the individual might take the form of flawed beliefs or myths. So to kind of illustrate this, on page 527 down at the bottom, there's a purple table, and it's called Myths versus Facts about Abuse. So if somebody is believing certain myths, like that their own behavior caused the violence, that battered women are masochistic and like to be beaten. I mean, there's a lot of really strange myths here. Other myths that the victim might believe is that I can't live without him or her. If I had only done this, it wouldn't have happened. I will stay for the sake of the children. He's jealous because he loves me. So yeah, it's kind of interesting when you read through those. So sometimes if people develop flawed beliefs, that's kind of a way for them to cope with the situation. And many times they even further withdraw from other people because they do feel a lot of shame and stigma about their situation. So definitely we need to look at the individual, and then we also need to look at family coping patterns. If any of you are parents, or if any of you have elderly relatives, you know firsthand that it can be very frustrating sometimes dealing with people. So even if you don't have children or anybody in your family that's elderly, just dealing with friends or roommates or boyfriends, girlfriends, spouses can be a little bit challenging sometimes. So we really need to look at how people are coping with each other, and if they have any healthy types of outlets for stress. We all need outlets to relieve our stress, and we're hoping to assess for some healthy ways that the family copes with stress. And if they have a healthy outlet, like they're able to spend time doing some fun activities and they're not constantly feeling like they're saddled with responsibilities and they never get a chance to have any rest or relaxation themselves, because that certainly is a setup for somebody to be abused. You know, if people are just so frustrated that they don't ever feel like they get a break. And then going along with that, does the family have any support systems? Are there people that they can rely on that might actually give them, not only lend an ear if they're feeling upset or frustrated, but also possibly to lend a hand and to help them with their situation? whether it be friends, other family members, neighbors, or even community agencies. Because again, sometimes people in these situations tend to isolate themselves, or they tend to perhaps be isolated by their abuser, and they may not be reaching out and using their support systems. We always want to look at suicide and or homicide potential. So somebody may become so completely distraught about their situation that they may feel there is no hope, and the only way to escape the situation would be to commit suicide. So that is certainly always a risk that we need to assess for. And homicide potential, certainly we need to think about the safety of that person who is being abused. Is the perpetrator homicidal towards them? Have they been threatened? Have there ever been weapons shown or used? So we definitely need to assess for those types of situations, but also think about the possibility that the person who's being abused may feel homicidal towards the perpetrator, the person who's abusing them. So they may actually have a plan to kill that person, and maybe they feel it's warranted, it's due to self-defense, or they feel like if they don't kill this person, they're going to be killed. So we need to be assessing that too. So other things to look for in terms of suicide homicide potential would certainly be to think about, are there guns in the home? Is there drug and alcohol misuse? Is there a history of violence on the part of the perpetrator? And is that extreme jealousy and obsessiveness on the part of the perpetrator evident? So all very pertinent nursing assessments. And again, always drug and alcohol abuse. Talked about that a few times already because of the way that it decreases the inhibitions and possibly can act as a precipitant to violent behavior. So the nursing process, following along with that, after we make our assessments, we make our diagnosis. Certainly risk for injury and risk for violence would be two very high priority diagnoses. Some other diagnoses might be pain, risk for infection, fear, powerlessness, chronic low self-esteem. I would think that would be a very, very pertinent one, and ineffective individual coping. And then when we are formulating our outcomes, of course, we're always making our outcomes with the patient, with the person who is going through this terrible situation. We certainly can't make goals for that person, but they really need to be made together. And the goals are really focusing on two big areas: protection from the abuse that has already happened, and then recovery, and also protection from future abuse, and recovery from the abuse that they have already been through. So two very important things to focus on. Overall, with the outcomes, we really are looking for the physical abuse to stop, the emotional abuse to stop, the sexual abuse has stopped, financial exploitation has also stopped. So those are some things we're thinking about when we're trying to develop outcomes. Plannings. So we have guidelines developed by the Joint Commission and the Nursing Network on Violence Against Women. Basically, the general tolerance of violence in America must be addressed if long-lasting changes are to be made. So again, we could probably talk for a couple hours about different instances of violence in the United States and how we do seem to promote violence and accept violence. We do tolerate quite a bit of violence in our culture, and if those things aren't addressed, it's going to be very difficult to see any types of changes. And the one court case that that I had brought up earlier, Brock Turner, that's only one case. There are other cases too of college athletes and in general sexual assault on college campuses as an issue. And we do have to look at the way that society views those assaults and the legal ramifications and what happens in the legal system when those cases come to court, because what happens there oftentimes does reflect what's going on in our culture. We also have to realize that nurses encounter people that are going through abuse situations very frequently in many different types of healthcare settings, and that nurse is often the first person of contact for people experiencing abuse. So they're really in a good position to be helpful. So hospitals usually have protocols, and usually the interest of the patient and the patient's safety should be absolutely always our very first priority. And also, just of note, the Joint Commission requires staff education in family violence and abuse, as well as the development of standards of care to guide our clinical practice. So the implementation, reporting abuse. Nurses are legally mandated to report suspected or actual cases of child and vulnerable adult abuse, and that would include elder abuse. Other types of vulnerable adults could be somebody who has developmental delays, perhaps somebody that's had a brain injury and is not able to think and speak on their own behalf, somebody who is legally not their own person. So we are mandated to report abuse, and it doesn't have to be, we don't have to have absolute proof. You can just report something that you're suspicious of. In, let's see, in your book on page 530, they give a little vignette about it sounds like there's a little bit of a discrepancy between the physician and some nurses in terms of possibly reporting abuse. It looks like the vignette is just like in a little purple table kind of in the middle of the page, and it sounds like the physician thought that the nurses were kind of overreacting and jumping to conclusions, and the nurses thought the physician wasn't taking things seriously enough. So it is really interesting to kind of read that, and I wonder how often that truly does happen in practice. So we just need to be, even if we just have some suspicions, we do need to report. And it may vary from state to state, so the book doesn't really, the book is used obviously probably all over the United States, so they're not going to be teaching specific areas where you would report, but most of the time in most states, child protective agencies exist specifically for child abuse, but perhaps for an elder abuse, there may be other areas too in which you would be reporting, such as your county health department, possibly law enforcement. There might be in other states child welfare agencies, juvenile court. So I'm certainly not going to ask you a test question on like where you would report, because that's going to vary from state to state, but just know that we do have to report it. And again, there may be differences among the states whether the report is written, verbal, and the time frame in which we need to complete that report. So that's part of the implementation or the intervention. So we really want to try to get that child or adult to safety. And it's also just thinking about an adult who is their own person and who is not considered a vulnerable adult, and they're not a child and they're not an older person. So just somebody who is maybe in their 20s or 30s and they're completely their own person. Sometimes the question may come up, can we turn that perpetrator in for them? Can we file a police complaint or a police report on that abuse? And again, that is going to vary from state to state. So there may be some states that say, yep, we can do it, and other states that will say, no, the person who is the victim needs to file their own complaint or give consent for that. So again, just some variations. Coming up with certainly doing some counseling and trying to encourage that person to think about what's best for their safety, and coming up with that safety plan. There are times when people just aren't quite ready to leave that relationship, but you do want to help them develop a safety plan for the time that they are ready to leave. So many times having a safety plan will include almost like the type of behavior that you do or the things that you do to get ready for when you have a baby. So you have your bag packed. You have everything in there that you need, so you can just grab it and run out the door when you're going to have your baby. So it's very similar to that. So medications, prescriptions, important legal documents certainly would go in a bag like that, or in some kind of a container that you could just kind of grab at the last minute when you're kind of running out the door. So that would be part of that, developing that safety plan, because you certainly there are things that you would not want to leave behind: credit cards, purses. So that's one aspect of the safety plan. The other certainly is, where are you going to go when you are ready to leave that relationship? It could be a friend or a family member that would be willing to take you in. It could be a shelter. So we certainly need to give people information, especially women, about women's shelters for abuse, just in case that is something that they would consider at the time that they're ready to leave the relationship. On page 531, there's a really nice paragraph that talks about this issue, and they talk about even having like a code word that when it's time to leave, and also trying to help the person to come up with what exact signs and symptoms will tell them now is the time to leave. So if they really think that through ahead of time. And again, if children are present, they talk about using kind of a code word that when spoken by the parent means it's time to go. So planning that ahead might really help them to be able to leave before the violence actually occurs. And it's also really important to just really stress to people that they have a right to live without fear of violence, and that they don't deserve to be hit, that no one deserves to be hit. So their self-esteem is possibly so low that they may not even consider that anymore. Case management. That would be a great thing for a community mental health nurse to be participating in, and that would be basically coordinating the delivery of services to victims. So the nurses would be possibly working with and coordinating community, medical, criminal justice, and social service agencies to provide them with different types of assistance. Always need to be promoting a therapeutic environment, especially if the patient is in the hospital. We have worked with battered women in the hospital on 1K. That's usually not the reason for their admission. Their admission is usually based on depression, anxiety, and many times suicidal ideation, and possibly sometimes even drug or alcohol abuse. So promoting a therapeutic environment in which they feel safe, physical and psychosocial safety are very important things. Certainly we want to encourage that person to talk about their situation as much as they feel comfortable, and also then to problem solve and grow in their coping skills and in their self-esteem. So we always want to be promoting self-care activities because, again, because of the low self-esteem, these women may or may not be taking care of themselves. And again, sometimes the victim certainly or the survivor certainly can be male. It's just that because there's a higher proportion of women who are in these types of situations, that's why I'm kind of saying she most of the time. But just keep in mind that a victim or survivor certainly can also be male. But just promoting basic, simple self-care activities is very important. They are neglecting eating and drinking appropriately. They're neglecting their sleep. they're neglecting any type of diversional activity or hobbies, things like that. So we really need to help them when they're in the hospital. Health teaching and health promotion, again, just basically taking care of themselves, seeking health care as appropriate. Nurse also has a really great opportunity for health teaching and health promotion in terms of helping families that are at risk for abuse to kind of identify some different areas and recognize behaviors and situations that might trigger that violence. So just explaining normal development and physiological changes might help the family to understand that person a little bit better. Nurses who work on maternity units are in a great position to identify risk factors when they observe certain things about the parents and possibly the bonding or lack of bonding that they're seeing. So some of you may have noticed that when you did clinical, if you had clinical on the OB unit, you may have noticed different aspects of bonding that were present or that weren't going very well. So when you notice new parents whose behavior towards the infant is rejecting, hostile, or indifferent, teenage parents who require special help with that baby, parents with cognitive deficits, parents who grew up watching their mother be abused. So those are all kind of risk factors that the nurse can be very instrumental in intervening with. Actually had the opportunity on 1K to work with a mom who had a baby recently and also had a toddler, and she was pretty much referring to the baby as it. She would not call the baby by the baby's name at all, and this went on for quite a while into her admission. So that was very, very difficult for the student and for the staff to work with this person, but it also was very rewarding when we could see things kind of starting to turn around a little bit. So our interventions are very helpful, can be very helpful in these types of situations. So prevention of abuse, so primary, secondary, and tertiary. So primary prevention in general, I'll just define those for you in case you forgot what those mean, but I'm thinking you probably had these possibly in health promotion. Primary prevention is always geared towards people before they have a health issue, so it's a healthy population. Secondary prevention is usually screening, because you are looking to find a problem early, and if you find that problem early, you can intervene and help that person to get back to their usual state of health rather quickly. So it's screening, and it's also all of the interventions that we do when somebody is in the hospital or nursing home, whatever health setting we find them in, all the things that we do as nurses to try to get them back to their usual state of health. Tertiary is the condition is permanent, it's fixed, it's not going to get better, and we are helping people with their dealing with the consequences and living to their highest functional ability, including that disability. So think about somebody who's developed diabetes. Usually we don't hear about people reversing their diabetes or reversing their heart condition. Yes, things can improve, but they will always have to kind of monitor that condition and take care of it. Somebody who's had a head injury or possibly a spinal cord injury, and perhaps they are unable to move their lower extremities. Well, that's a permanent condition, not likely to change. So how can we help that person be the healthiest they can possibly be and, deal with that disability in the best way possible? So relating this now to abuse, so primary prevention of abuse really deals with certainly measures taken to prevent the occurrence of abuse. So teaching would be huge in this area, and teaching is actually a huge intervention for primary prevention. So we want to get at people and teach them before they develop the problem. So teaching is a really great way for us to do that. It also deals with changing society's views towards violence, things like that, and possibly television shows, cartoons, the media, all of that. But of course, that is something that is not easily going to be undertaken by, by one nurse or even a group of nurses. I think that's a concerted effort in society in general. But anyways, so that's primary prevention. Secondary then is early intervention in abusive situations, again, to minimize their disabling or long-term effects. So screening is part of that. Screening and picking up on it early. That's why we do need to ask those very important questions when people are admitted, when they go to the hospital or when they go to the doctor's office. We need to be asking the right questions and trying to pick up on signs and symptoms as quickly as we can. Tertiary then is facilitating the healing and rehabilitative process, so that person, instead of feeling like they're a victim, they can become a survivor, providing them support and assisting them to achieve their optimum level of safety, health, and well-being. So, an audience response question: child abuse perpetrators are most often extended family members, child care workers, the child's parents, or strangers. So, unfortunately, it's C, the child's parents. So, statistically speaking, that is the greater percentage of child abuse perpetrators are actually the child's parents. Another question: should nurses be legally mandated to report intimate partner abuse? Yes, no, or not sure. So again, it's not a trick question. It's just basically, again, something to get us thinking about it. And it may, in some states, it actually may be, nurses may be mandated to report domestic violence in a person who is not considered a vulnerable adult. They are of age and they are of sound mind, and legally they are their own person. It may be in some states, we may have to report that. In other states, we don't report it. But it is kind of like an ethical dilemma, whether or not we should be reporting that. So just something to help you think a little bit. So now we're in chapter 29, sexual assault. And so just an image that I found basically about stopping violence against women, and all kinds of words are in there: offend, humiliation, cruelty. So just things, insult, things that we have to kind of think about as far as violence towards women. And again, as think about different aspects of our culture that might actually promote that. So lots of work to be done. So sexual assault and sexual violence. So basically, the definition is being as unwanted sexual advances and harassment. These can include, sexual violence really does include stranger rape, which doesn't happen near as often as rape that happens with people that you know. So stranger rape, marital rape, date rape, drug-facilitated sexual assault, incest, human sex trafficking, and female genital mutilation. So those are all different types of sexual violence. One aspect of sexual violence and sexual assault that has been getting a lot of attention recently is that human sex trafficking. There is a police officer in Sheboygan who gives talks, 2-hour talks on this topic, and she's given many talks throughout the community. Not sure if she's hitting Manitowoc County at all, or if it's just Sheboygan County. But she certainly seems to be aware of the problems going on in Manitowoc County also. I went to hear her talk last summer sometime, I think it was in August, and it was just completely shocking of what goes on in our community with human sex trafficking. And it's all ages. It's not just young girls, young pretty girls. It's all ages, male, female, all the way up through middle age. I haven't really heard of elderly people being sex trafficked, but certainly men, women, any age can be sex trafficked. So that is, if you ever have the opportunity to hear her talk, her name is Detective Tamara Remington. So if you ever see a human sex trafficking talk, go to it. It really is eye-opening and just really, I think, important for us to be aware of in our own communities, that all this stuff is happening kind of right in broad daylight most of the time and right under our noses. So if we can be aware of what sex trafficking looks like and what the typical scenarios are like, it's very possible to help victims. We had a patient in the hospital last year who we probably strongly suspected was being sex trafficked. But the patient was over 18, and we really couldn't do anything about it to prevent her from leaving with this particular person that she didn't really know. So she basically was going through a situation where she met this woman when this woman came to visit her, and she said she was from a church, but really we were kind of suspicious as to what her credentials were, and why would she just show up at this girl's ICU bed and be talking with her and praying with her, and then coming to visit her on 1K and then offering for her to come live with her. So we were just a little bit suspicious of that, and really wondered if she wasn't being sex trafficked. And we brought that to her attention and told her that it is very possible that this was happening. And the girl really was in denial. She didn't want any help with the situation. She felt like she would be okay living with this person. And sometimes they do use females to get other females into the sex trafficking business. So basically, this woman who was middle-aged and who went up to the ICU and visited this girl might seem like a safe person. It's safer to perhaps to engage with that person than perhaps if a man went up and visited her and then was encouraging this young girl to live with him. You know what I'm saying? So it was probably a little bit more like, oh, okay, this is a nice person. I think, it's another woman. I think I'm going to go live with her, even though this patient didn't really know this person at all. So, yeah, we really did. We tried so hard to try to convince that girl that she was possibly going into this type of a situation. But we talked to the mental health counselor and social workers, and truly it ended up being nothing that we could do to prevent the discharge from happening because the girl was of age. So very frustrating, and certainly hope that the worst didn't happen, but I guess we just have to really be paying more and more attention to this as it becomes a problem in our community. So, rape, the definition is non-consensual activity. So the person is not giving consent. And there are maybe lots of different reasons why somebody cannot give consent. So we have to think about if that person is unconscious. So perhaps they're under the influence of drugs or alcohol. Perhaps they just simply drank too much, or somebody gave them a date rape drug. So they're unconscious, they're asleep, they have some form of developmental delay, head injury, brain injury, something like that, where they just are not their own person, and they're not of age. So if they're underage, that would also make them not able to give consent. So it's basically, the definition is any penetration of the vagina or anus with any object or body part, or the oral penetration by a sex organ of another person. It is considered the second most violent crime. by the FBI in a group of crimes that include murder, robbery, and aggravated assault. So we really do have to think about this. Again, we have to kind of change our culture and really take this very seriously, that this is a violent crime. There are times when people want to blame the victim and accuse the victim of being seductive, of drinking too much, of wearing, seductive clothing, things like that, and basically as if to say they were asking for it, that they caused that rape to happen. And we really truly have to change our mindset and realize that it is a violent crime. Period. End of discussion. That's what it is. So epidemiology, 1 in 5 women and 1 in 71 men in the United States have been raped at some time in their lives. So we do have to realize that this is a male and female issue, but of course it happens more to females than it does to males. As for race and ethnicity, there's a table on page 540, right up at the top, a purple table that talks about the lifetime prevalence of rape, stalking, and sexual assault by sex and race and ethnicity of the victim. So basically, I'm just looking at the first column on the left, women, and multiracial has the highest percentage, followed by American Indian, Alaska Native, followed by Black, non-Hispanic, followed by white, non-Hispanic, and then Hispanic is the lowest, 13.8%. So we do have to look at that as part of the epidemiology. Sexual offenders and relationships with victims. So again, it is more often that it is the perpetrator is somebody that the victim or survivor knows versus stranger rape. That is actually the least common type of rape. So spousal or marital rape and acquaintance or date rape. At the bottom of page 540, your book talks about the fact that if somebody knows their attacker, so if it's spousal or marital rape or acquaintance or date rape, that women usually are going to have more sexual distress, and people that are raped by strangers have more fear and anxiety types of responses, and depression is very common in both of those groups. Acquaintance or date rape also has increased in the United States, and drugs many times being combined with alcohol, and sometimes those drugs aren't even being screened for because the effect of the drug so closely mimics somebody who is under the influence of alcohol. The other problem with using the drugs in a date rape type of situation would be the drug induced would be that the woman many times has amnesia and truly can't remember what happened, and therefore it's difficult for them to actually give testimony and to be an accurate witness. So psychological effects of sexual assault, absolutely acute stress disorder, and if the person doesn't get help, it's very possible that that can turn into post-traumatic stress disorder, which would be the longer-term impact of the disorder versus acute stress disorder. We hope would get better with time and with therapy. But if that person, again, doesn't get help, they're going to be developing post-traumatic stress disorder. Absolutely, depression, suicide, anxiety, fear, difficulties with daily functioning, absolutely low self-esteem. Yeah, partly, certainly because of what happened, but, if you think about the types of stigma attached with being attacked, and also just the stereotypes again that people have. What were you wearing? Why were you in that area? The types of questions that people ask, making it seem as if it was the victim's fault. So that can totally wreak havoc on somebody's self-esteem. They may end up having sexual dysfunction, and again, many times those somatic complaints because they can't always talk about what they're feeling. So our feelings then get turned into bodily complaints. So effects of incest, again, very similar. Incest victims may experience negative self-image, depression, eating disorders, personality disorders, self-destructive behaviors, and substance abuse. So, case study. Indira, a 20-year-old woman, is brought to the ED by two friends who say that Indira has been raped. You are the attending nurse. Indira's friends say, we were together at this party for a friend from school when these guys introduced themselves and one asked Indira to dance with him. We tried to keep our eyes on her, but we lost track of her somehow till we found her in a bedroom upstairs. She was all messed up and crying. So what information should not be obtained during Indira's initial medical exam? Ascertaining what she might have done to provoke the situation, documenting biological and physical findings, collecting evidence, or arranging follow-up as needed to document additional evidence. So I'm hoping that you picked A. That should never be. We should never be trying to ask what she might have done to provoke the situation. So that is just completely not appropriate. Another case study discussion. What would be some appropriate questions to ask Indira to determine her coping mechanisms? So we certainly can ask, how she copes usually with situations that are difficult. However, we also have to recognize that if truly she was raped, that is possibly above and beyond her normal coping mechanisms. And so we really need to help her to get her into some counseling and to really bolster her support systems so that she can cope with the situation. It might be helpful just to ask, what are you thinking and feeling right now? What can I do to help you in this difficult situation? You can ask what has helped in the past. That may give, a little bit of sense of drawing on her own strengths and ways that she has coped in the past. So it's certainly okay to draw on those. I'm just saying that before that it's possible that this situation is going to be above and beyond what she has usually coped with. So, and then again, of course, we're always, when we're talking about coping, we're always trying to draw on those support systems too. What areas should you include in your assessment of Indira? So the next slide will hopefully give us some clues about that. So again, we're always using the nursing process. So in our assessment, we're going to be looking at her level of anxiety. And some people show it in really different ways. So some people laugh, cry, withdraw. They may use really all different types of behavior. They may be agitated, confused, disoriented, laughing or joking. So we really have to be looking at all those possibilities as showing her level of anxiety. Again, we're looking at her coping mechanisms, available support systems, signs and symptoms of emotional trauma and physical trauma. So usually, again, with any type of trauma like this, many times we do document on a body map. And there also may be some specimen collection that would also be obtained, and that would certainly be possibly done by the sexual assault nurse examiner. So a SANE nurse, S-A-N-E, sexual assault nurse examiner. That is a specially trained clinician to provide care to patients who have been sexually assaulted. One thing that's very important as far as the role of the nurse when we're assessing for the signs and symptoms of physical trauma is that we really want to make sure we don't re-victimize the patient when they're going through a genital exam. So many times it's the role of the nurse to be comforting and talking to the person throughout that exam, because it's very, it may remind them of the attack that just took place and can be very, very traumatizing. So it is definitely the role of the nurse to be able to give information and provide comfort and give that patient a level of psychological safety during that very necessary exam. As for self-assessment, it certainly is a very difficult situation. So again, it may really trigger a lot of different emotions in a person, in a nurse who's taking care of somebody who has been sexually assaulted. So basically, knowing the myths and the facts and just educating ourselves can really help us to be able to handle our own feelings during this type of a situation. So we really want to make sure that if we're working with people who have been assaulted, and we may in many different types of settings work with patients who have been assaulted, we really want to think about our own feelings and reactions so that we can really be giving empathetic and effective care. So some best practice guidelines. So the examination involves 5 steps: head to toe physical assessment for any signs of injury, a detailed genital exam, and again, the nurse would need to be providing comfort and hopefully engendering a feeling of safety for that patient during that difficult experience. Evidence collection and preservation, documentation again of physical findings on a body map, treatment, discharge planning, and follow-up care. So that's the best practice guidelines that nurses need to follow. So the nursing process, diagnosis, certainly rape trauma syndrome would be a very appropriate diagnosis, and the outcomes, we're hoping that the goal will be that we will find an absence of any residual symptoms after the trauma. So we're hoping to get the person through the acute stages so that they don't develop post-traumatic stress disorder. Interventions would include counseling, promoting the self-care activities as we've talked about before, case management in case they need coordination of several different types of services, and advanced practice intervention would be to provide psychotherapy. Overall, a non-judgmental and caring attitude towards that patient can be very powerful, and just really allowing them to talk and us being active listeners. So again, the SANE nurse, I talked about that a little bit before. So a sexual assault nurse examiner, and that's an RN with specialized training in caring for those sexual assault patients. I believe we have a new staff member at LTC who is a SANE nurse, and so she would be providing that specialized care when patients would come in who have been assaulted. They have demonstrated competency in conducting medical and legal evaluations, and very interestingly, they can be an expert witness in court. So they may actually be called upon to give expert testimony, and they would be very helpful possibly in the victim being awarded for, certainly for damages, and the person who assaulted them to be prosecuted. SANE nurse is usually part of the Sexual Assault Response Team, or SART, and that's a more of a multidisciplinary team approach. So the nurse would be a part of that. So the other disciplines that would be involved possibly would be physicians, attorneys, social service workers, different types of advocates or mental health professionals, forensic laboratory personnel, and any other type of agency that might provide service to a person who's been assaulted. So the evaluation that we hope that what we would find would be that the sexual assault survivors are considered to be recovered if they are relatively free of any signs or symptoms of acute stress disorder and PTSD. Some of the specific things that we would look for in order to make that evaluation would be If the person is sleeping well with few instances of nightmares or broken sleep, eating as they did before the rape, being calm and relaxed or only mildly suspicious, fearful, or restless, getting support from family and friends, generally positive self-regard about themselves, and the absence or only mild instances of somatic reactions, and returning to pre-rape sexual functioning and interest. So those are things that we would look for to assess that person and evaluate that our interventions have been helpful and that person is on the road to recovery. So this is the end of Learning Plan 8. So I will see you again in Learning Plan 9.